Good afternoon, everyone. Welcome to our weekly CEO Desktop Chat, where we will be providing you updated information regarding COVID-19 and other efforts that we're undertaking in terms of our ability to manage the pandemic, but also take care of patients as we move forward. There'll be some information you will be receiving today that takes a look at what that future may begin to look like, and some other activities. So remember, at the bottom of the screen, there is an icon where you can submit questions that we will then pose to the panel at the end of the presentation. So please post those there. And before we begin with Del Vecchio starting off with comments, we'll go around have the panelists introduce themselves. I am Terry Lightfoot. I'm Public Affairs Director here at Alameda Health System.
I'm Janet McInnes, the Chief Nurse Executive, Chief Administrative Officer.
I'm Rachel Baden. I'm the Chair of Medicine at Alameda Health System and an Infectious Disease Specialist.
Tony, you may be on mute.
And I'm Tony Redmond, the Chief Human Resource Officer who does not have to use Zoom.
All right.
Okay. All right. Good afternoon. Good Wednesday afternoon, everyone. It is always great to connect with you all, and really appreciate, as stated before, all of these weekly check-ins with all of you. Appreciate all the wonderful questions you ask and your continued engagement and support of our patients, our community, and one another. Begin to think about your questions as I walk through a couple of quick high-level updates during today's desktop chat, and we'll get to that Q&A portion that we so look forward to in just a brief moment. So let me start off by actually saying today, as I understand it, is the official launch of Nurses Week. And as it's every year, we want to really highlight and thank and appreciate all of our nurses, our wonderful nurses throughout AHS in our inpatient settings, our skilled nursing settings, our outpatient settings, behavioral health, and otherwise, who really have such unwavering passion for our patients, not only during this pandemic, but always. And in a few moments, you'll actually hear a bit more about this from our Chief Nursing Executive and Chief Administrative Officer, Janet McInnes. So I'll pause and just say that much at this point. On today's chat, we'll also talk about the restoration and recovery phase of our command center operations and our work related to our response to the pandemic for our system. And as usual, we'll give an update on the COVID-19 response as well. So I want to start where we gave just a little bit of hot off the press update last week, and this is regarding the changes throughout the Bay Area and the state with respect to sheltering in place. So the Bay Area health officials announced an extension of our regional shelter in place through May 31st, while easing some of those rules. And we got a little bit more update of the easing of some of those rules later in the week. But the health officials warned that reducing restrictions too quickly could lead to a resurgence of COVID-19 in our community, and that we should always continue to follow the guidelines that are put out, those of which you can find on our coronavirus resource page. Those new orders affect certain industries or certain parts of our economy, including construction projects, real estate transactions, childcare facilities, and certain outdoor businesses. They clarified that outdoor businesses do not include restaurants, cafes, or bars, regardless of whether they have outdoor seating. We are expecting to hear more about the furthering easing of these restrictions in the coming days. There are a couple of other things that the health officers are going to be tracking as we continue to monitor our performance across the Bay Area and continue to look at things that we could ease in terms of restrictions. Those are things like use of hospital capacity, ICU capacity, so that we can be prepared for any sort of spikes and surges, obviously new and expanded testing and hospitalizations that may be related to COVID-19. We'll be looking at other matters as well, and looking at how they will track those and share those with us as we and other organizations move towards restoration of services. And I'll talk a bit more about our own efforts in that in just a second here. But just as a reminder, as the health officers did, I want to make sure that I remind you to continue to mask, and wear masks in our hallways and in our public spaces throughout the organization. I appreciate all of you who are doing that and being very diligent in your efforts. We want to make sure we continue to protect our patients, our coworkers, and you, and to keep you safe. Now, just speaking a little bit about our restoration of services. So during the early weeks of the COVID-19 pandemic, as you know, we halted many of our elective surgeries and procedures. We were able to move a lot of things into a non-traditional format like telemedicine, our telephonic visits, and now video synchronous visits as well. Those have really helped to protect our patients, helped to protect our staff and our community, and we're in compliance with prevailing public health guidance, as well as local and state health shelter-in-place orders. Now, thus far, we appear to have, throughout the Bay Area, have avoided a situation where ICUs and inpatient settings across the Bay Area have been overwhelmed by the needs of the pandemic, but we will continue to remain vigilant in this effort. And I just take a moment to parenthetically say, as we should always say, we honor and remember the lives of those individuals in our community and throughout our state and our country who have fallen victim to COVID-19, and we have lost in our families and in our circles of friends and loved ones. So we always want to make sure that we are mindful that there's been real harm and real injury as a result of COVID-19. But as it relates to the surge, we have not had a situation like we've seen in other states and other locations where ICUs and hospitals have been overwhelmed, and we feel fortunate for that and really appreciative of all the efforts that have been done throughout our community to make sure everyone was safe. So now local and state health leaders are asking us to calibrate that continued vigilance with making sure that we do continue to meet the care needs of those individuals in our community whose care needs were either delayed or canceled as a result of some of these shelter-in-place orders and other pandemic surge preparation needs. So we're looking at how we will safely resume those services and meet those needs, care needs for members in our community. We, within AHS, are now formalizing this process. We've had many leaders who've been proactively, whether in certain services or at certain campuses, parts of our system, who've been looking at how we can continue to or increasingly meet those needs of our patients. But we're going to formalize this process just this afternoon, actually, come up with timelines and actual plans where we will start to approve and authorize the restoration of services that have been suspended during the surge. We have convened a small oversight team that will provide guidance and coordination across our system. This process will engage the expertise and insights of all of our clinical dyads that are impacted here. We're talking perioperative services, ambulatory services, including procedural areas in OB and dental and a couple of other areas, some of our diagnostic areas. We will rely on the guidance of our medical and technical experts, including infectious disease with Dr. Baden here, as well as employee health and other areas. Our STAR team, in terms of system transformation, will be helping us with processes and things like that, as well as in our supply chain, ensuring that our PPE stock is continuously updated, and we're mindful of that as we move forward with services, but also our other supply chain for surgical instrumentations, implants, and other sorts of needs that we will need to ramp back up as we resume services. Our plan will require clear understanding of the level of support that we can anticipate from our community partners as well, particularly around the broader availability of testing of PPE and access to services that will allow us to sustain improvements in certain safety and operational performances, like inpatient throughput and length of stay, PES census management, and a couple of other areas. We want to make sure that we are implementing best practices that have been developed during our coronavirus preparations that created a clear path forward, reducing variability across our organization, and setting specific guidelines to ensure alignment across the system. This will be important as we ramp up traditional services and remain poised to respond to the ongoing presence and the potential surge of COVID-19 in our community. I'd like to pause now and turn it over to our Chief Nursing Executive, Janet McGinnis, to talk about Nurses and Hospital Week. Janet?
Thanks, Delvecchio. So on behalf of Alameda Health, we just wanted to share our gratitude. This Nurses Week and Hospital Week is like no other as we find ourselves in the midst of a pandemic. Now more than ever, the world understands how much we appreciate all the hard work you do daily to ensure hospital systems like ours can provide care to vulnerable patients. I stand in amazement at the courage and gallantness that you've shown during this pandemic. You put your fears aside and joined the front lines to ensure that all of our patients were taken care of. Whether they had COVID-19, chronic illness, were in labor, or had a regularly scheduled medical visit, you were there. You put our patients front and center and coordinated visitation at the end of life for COVID-19 mothers who had to see their newborns through a screen, and for so many others who were impacted by the disease. You did that, and you did it with an enormous amount of kindness and empathy for our patients and your peers. I know not everyone provides direct patient care, but the work that we do directly affects the care delivery in some shape or fashion. Whether you're in billing, information services, human resources, or communications, your work is vital to ensuring that we can deliver high quality, safe care. I can't express how thankful we are for your flexibility, ingenuity, for putting aside differences and coming together as a team. COVID-19 has been an amazing journey, and I put that in quotations, with many lessons learned that I know will better prepare us to face adversity in the future. Because of social distancing restrictions, we aren't able to hold our celebration for Hospital Week and Nurses Week, but it isn't being canceled, it's just being postponed. Once all this dies down, stay tuned, because when it's all over, we'll be celebrating the victory that all of you made happen. Tomorrow, however, a caravan of East Bay first responders will be touring to various healthcare facilities to salute healthcare workers for their commitment and dedication during COVID-19. Highland was selected as one of their stops, and they'll be arriving via Beaumont, passing on the East 31st wing of the hospital. If you're able, please go outside or look out your window and receive the love from all of our healthcare providers. So again, I can't tell you how proud I am on behalf of Alameda Health and everybody that's on this chat and that works here. You guys have done an amazing job. And as the sign says, nurses rock, but hospital employees rock as well. So thank you.
Thank you, Janet. That's just wonderful. We're really excited to recognize the nurses and our frontline providers and everyone who works in our hospitals, as well as throughout our system. And really, every day, want to thank you for everything you do for our community and for each other. Before I open it up for Q&A, I want to do my usual reminder for self-care and wellness. As I announced, I think last week or the week before, we are now posting our Wellness Wednesday messages on the internet, and many of you have seen them. The one that we posted last Wednesday was entitled "Be Proud of Yourself." So don't wait until you've reached your goal to be proud of yourself. Be proud of yourself for every step that you take towards reaching that goal. And please look out for those updates. And then, as I say, check in with your family members, check in with your loved ones, near and far. Make sure they're okay. Make sure they're taking care of themselves, and you do the same. I want to thank you again for everything that you do to help us to advance our mission of caring, healing, teaching, and serving all. And with that, I say take care, and I want to turn it over to Terry and my panelists, and we will receive and try our best to respond to your questions. Terry?
Thank you, Del Vecchio and Janet, for those wonderful comments. I'm sure they're much appreciated by all of our staff, so really appreciate you giving that shout out this afternoon. We have about 400 folks who are here so far with us today. That's a great number. For those of you who have joined during the conversation, please know that there's a Q&A icon at the bottom of the screen. Please click on that, write your questions into the field, and we will try to address as many of the questions as we can with time permitting. So there's been a lot of questions about testing and comments around testing. So we will jump right in. And actually, this person has been called out specifically. So Dr. Baden, you've been a part of this question. This is directed at you. So, and I don't know what this acronym is, so I hope you do. Have there been any DIC type cases with the COVID-19 patients?
So I think what this question is referring to is all the reports that we've seen in the lay literature and also emerging in the medical literature about clotting issues specifically around COVID-19. And DIC stands for Disseminated Intravascular coagulopathy. And so what we have seen this here at Highland, and basically as part of your immune system's response to this virus, it tends to dysregulate not only our immune response, but some of our clotting mechanisms. So we have seen patients in DIC. We actually had a patient who had a stroke as well. And so we've seen some of the things that have been reported in the literature around clotting issues, and we're aware of it. And our treatment guidelines do reflect the need to have full-scale prophylaxis on board with heparin. So we've addressed it conservatively in our treatment guidelines and continue to monitor patients closely for this unintended and sort of unexpected consequence of this disease that we are seeing.
Thank you. There's been a lot of conversation about the drug remdesivir in terms of its lessening or shortening the time frame in which COVID-19 impacts patients. Has there been any attempt here at Alameda Health System to acquire that drug?
Yeah, great question. So remdesivir is a direct-acting antiviral. It's a polymerase inhibitor, which has been studied for a little while now in other viral diseases. And then early data suggested it may have some in vitro activity against COVID. And then in the last week or so, we've seen some initial clinical trial data emerge that it may have some efficacy in treating this illness as well. So it's with a grain of salt because none of us have actually seen the entire peer-reviewed manuscript, but there have been reports of it lessening the duration of disease by a few days and then decreasing mortality compared to a small control group. And so this is really potentially promising data. And so with hopeful optimism, we'll await the rest of the data. But in the meantime, what's happened is last Friday, the FDA, on an emergency basis, approved this drug, which now means that we can prescribe it and you can have access to it outside the setting of a clinical trial. And so starting Friday when this was released, we had our pharmacists on the phone trying to procure this medication for our patients, our severely ill patients at AHS. It turns out how this drug is going to be distributed by the federal government, which is interesting. So Gilead, which is the pharmaceutical company that manufactures remdesivir, has given all of the supply they currently have to the federal government. And then the federal government is going to dole it out as they seem appropriate based on how they deem folks in certain areas if they're COVID hotspots. So we have talked to our distributor, and AHS or our area is deemed a COVID hotspot. And so ostensibly this means we will be receiving some amount of remdesivir for use in certain settings. We don't know when or how much, but we're hopeful we will be receiving some. And when we do, we will certainly let everybody know. And then we'll provide some guidance in terms of how we think it most effectively and most appropriately can be used, since we will have very limited doses.
Great. Thank you.
Can I, Terry, before you go on, so Dr. Baden, that's very helpful and comprehensive information, very much appreciated. I think I'd read something that sort of reflects what you were saying at the end there, that with the distribution, there was no real proactive way that organizations could request it per se. They were going to be reaching out to us and saying, here's what you will get and when you'll get it.
That's correct. I think that is correct. We've been really aggressive in terms of reaching out to our distributors. They know we're ready to accept it, and then they'll let us know when it's going to be distributed. We haven't heard any other update. I don't think there's any further advocacy we can do. We're already, quote, deemed in a hotspot. So that's, we're told, is what's necessary in order to receive drug.
That's really helpful too. I was actually trying to find some language around if there were specific criteria for who determined where was a hotspot and kind of what the conditions were, because there's a separate set of pool of funds that were made available through the CARES Act for organizations that were deemed in hotspots and heavily impacted. And unfortunately, while we qualify for other pools of funding, we did not qualify for that because the criteria was a certain number of COVID positive admissions. So I should say, fortunately, we didn't have or haven't yet experienced that level of admissions, but that threshold meant that, or not crossing that threshold meant that we didn't qualify for the funding. So sort of some ambiguity about what is a hotspot for different things was something I was worried about. But it's helpful to know that we, at least from the distributors' perspective, they understand that the East Bay broadly is a hotspot, and that through that, or by virtue of that, we're likely to get some. So we'll just be mindful.
Yeah.
Okay.
Now, all of this could change. As you know, everything around this is fairly fluid, but we'll be sure to update people when we know more, when we have information that's different than what we're letting people know on this call. The other thing that we've been trying to do just to make sure that our patients have as much access to all the current therapeutics as they possibly can are two things. Number one, we have established a transfer policy in place for patients to be transferred to UCSF or one or other clinical partners if they can qualify for one of the clinical trials that are available at one of those places. And so UCSF, we have a workflow around transferring very critically ill patients there if need be. And then we're in the process of trying to become a site for some of the other clinical trials that are ongoing. There's a clinical trial that is opening up to study that's already done so tocilizumab, which is an IL-6 inhibitor, they've already studied it and done in a randomized controlled study, and now they want to open it up to study in an underserved population. So they contacted me this week about us being a site for that, which would be awesome. So I'm waiting to hear back whether we qualify. We gave them all the information they requested. So we'll be letting everybody know as we have more information as it unfolds. But I think the message to our community on this call is we're doing everything we can to ensure that our patients have access to everything that's out there as we possibly can.
That's perfect, and thank you so much for everything you're doing in that respect, Rachel. It's important for the role that we play and for our goal to make sure that we're advancing equity for the communities that we serve, and so I really am appreciative of everything you're doing in that respect. So back to you, Terry. But thank you.
Thank you both. There's the information that brought forward has indicated that Alameda County has the lowest per capita testing rate among Bay Area counties. What is AHS's plan in helping meet the need for testing in the community as we look at reopening our own services and broadening economic activity?
I'll start with what I know, Rachel, but I'd love for you to chime in with any insights you have. So I don't know the actual comparative rates of per capita testing. I do know that anecdotally, Alameda County is on the lower end of that spectrum, particularly in comparison to other counties with populations over 1 million, like San Francisco actually I think is not quite 1 million, but the testing is quite robust there, as well as Santa Clara County, I understand is quite robust as well. We are, we're doing various efforts. I'm a horrible second fiddle to Dr. Ng on this aspect, but I know that she and her team have been reaching out in a lot of contexts to our broad sort of testing options, both with the county public health lab, which is sort of our main route. We have some relationship with UCSF to take advantage of very robust testing capacity they have there. We still have Quest labs as an option for us too. We're looking, well, we have an in-house capability for rapid testing, but very limited applicability there, but glad to finally have that and stand that up, and we sent an announcement out about that yesterday. We are looking to work with the county to expand their capacity, and we've tried a couple of routes now, and they have been responsive. We've increasingly gotten more, but we do know that that's still a limitation for us, and we need more. We're going to be talking about it with our board on our COVID-19 task force meeting this afternoon. And I would just share, the last thing I'll share is one of the things that the Bay Area public health officers did or communicated as part of their plan to continue to monitor how well we're performing under this slightly relaxed shelter-in-place guidance is a criteria to expand testing on a per capita basis in each county. And I think the expectation is at least 200 tests per 100,000 people each day. And they're not even just looking at testing capacity, but it's actual testing. And so for us in a county that's over 1 million, I think about 1.5 million or 1.6 million, that will represent a significantly expanded amount of testing, so north of 2,000 tests per day. And we'll be looking to the county to understand all the different mechanisms by which they're tracking and capturing who's providing that testing, and making sure that we have expanded capabilities to support our efforts to resume services within AHS. So that's what I know, but Rachel, you may know more or have other information.
Yeah, I do know that our test per capita is lower than any other place in the area. I think we're at 28 tests per 100,000 people compared to the goal of 200 tests. So we have a lot of work to do as a healthcare system around this. I think our first priority should be based on CDC guidelines, opening up testing to all symptomatic individuals. So this would include ambulatory testing. And then the other thing that I think should come closely behind that is to open up testing to potentially screening all of our inpatients. And along with the ambulatory testing will be our need to establish some sort of testing pre-procedurally so we can open up elective surgeries and elective procedures again. So we have a lot of work to figure out for our healthcare system, and I think a short period of time to figure out. We had a meeting this morning again about it. I think the good news is we have the tests and then we have the kits. So we just need to figure out how we're going to operationalize it. But I do think this needs to be our #1 priority as a healthcare system right now.
I agree. Can I ask a clarifying question? Sorry, it's not that Rachel. I'm asking more questions than other people. I apologize, but Rachel's a wealth of knowledge, and I just want to ask this. So the 28 compared to the 200 goal, is our 20? I thought the 200 goal was for the county-wide testing, and I know in our case we're not directly like other county systems connected to the public health lab, where I think a lot of this capacity exists and it's being run out of. So I don't know what the public health lab capability is. Or were you saying that the 28 per 100,000 is actually all of Alameda County, and that's what's happening in the public health lab?
Yeah, I think so. I think there are two things here. So I think we sort of need to accept some responsibility in terms of what's happening within our county, since we are the safety net, and for many individuals, they won't have the option to seek testing elsewhere. And so I agree with you, Del Vecchio, that this is more than just Alameda Health System. This is an initiative that needs to be happening countywide. But I feel like it's incumbent on us to be leading it, and we're not. And so I think that we have a lot of opportunity as a healthcare system. I want people to know that we're all thinking about this, we're all working on it, and we're trying to figure out a way to make access easy and to operationalize this.
Absolutely agree with that. I just want to make sure that the comparison number, so that folks on the call are hearing this, is an apples to apples comparison of what's happening at a county level versus a organizational level, because I haven't quite confirmed that yet. Either way, I think what you just said is absolutely right, and that's what we're pushing for, to be able to expand more of the testing that we do here. So we're not just doing symptomatic ED patients and inpatients. We are doing symptomatic ambulatory and asymptomatic inpatients and frontline workers much more robustly than we are doing. That's definitely the goal. I just want to make sure that the current state comparison is accurate, so that we know our baseline.
Yeah.
Okay. Thank you.
Great. Thank you both. Janet and Tony, I know you guys are both veterans of the command center. The question is, the memos were coming out on a daily basis, and that departments or managers were asked to engage their staff relative to the information coming out in the memo. As we're ramping down the command center, what are your expectations around the need for continuing engagement between managers and staff on a daily basis, either as we're ramping down the command center, but also as we're looking at our restoration process?
So, Tony, I'll start and then chime in. I think first and foremost, we do not want to lose all the traction that we've made with the communication. I think we've discovered new ways to communicate, and it's been robust in a way that it perhaps hasn't been in the past. And so I know that the desktop chat will stay. I understand that there will be 2 or 3 memos a week that will continue to come out. The command center may go virtual at some point, and then we have a 4 o'clock call typically every day that we will look at and question people today about what their needs are. At the local level or the unit level, we absolutely want those communications to stay open. We want leaders to continue to round. We want managers and charge nurses and everybody in between to continue to communicate. As Dr. Baden mentioned earlier, things are very fluid and they change almost day to day. So as we start this restoration process, we don't want things to fall by the wayside where people are wondering, okay, is it over? Is it business as usual? I think we need to continue to quote unquote over communicate so that people feel comfortable that we're moving forward in a safe way. So, you know, I think it's, again, fluid. I don't know that we clearly understand what communication looks like in terms of a newsletter coming out, but that should be hashed out by the end of the week, and we will continue to stay in front of people. But Tony, anything to add to that?
Yeah, thanks, Janet. I think the intent of having managers meet with their staff was to ensure there was a direct connection and a flow of information from the command center all the way down to all of our employees. We were hearing feedback that employees were receiving some information in some areas, but not getting all of it. The objective is that managers are able to communicate with their staff about things that are going on within the organization. We happen to, formulate that around COVID-19 in that we were sending out a memo every day that we wanted to ensure staff got all of that information, and we're able to ask their manager questions, who in turn, if they needed to, could escalate them up the chain of command, and we could get responses to those. The fact that the command center has been going 3 days a week now in person, and that the communication is slowing down, doesn't mean we should really change those meetings. I think they're incredibly useful. I think employees will continue to have questions. We want those questions to be raised, and if the manager has an answer, for the manager to respond to it, so the employee doesn't need to go somewhere else. If it then needs to come to the command center or up the chain of command to their director or vice president, then that's how it should flow, and we should then get that information back to the employees. Keeping them informed is going to keep them focused on their work, feel that they are comfortable around the work they perform, and then able in turn to provide services to our patients. Really, we just want to keep that communication going in that way and ensure that the employees have all the information they need. And if we're falling short, that then we find out and we do something about it quickly. And this is the best way that we can continue to do that right now.
Yeah, thank you. I just wanted to add one more thing, that if there are specific things that people feel they're lacking, or there's a different or better way for us to communicate, I think everyone on this panel, and certainly everyone in the leadership team, is more than open to hearing those. Not necessarily that we can, fulfill every need, but our goal is to communicate as best we can. So if there's ways that we're not doing it, that you want to see it, go ahead and ask us. We're open to that.
I really appreciate you saying that, Janet, because I was going to echo a similar sentiment. And if I may, I'm going to be presumptuous here. I would offer that anybody on this panel and other members of the executive leadership team would be more than happy and would consider it a privilege if people are holding their huddles or weekly or whatever the frequency is, meeting with their team, and they wanted to invite one of us to provide some direct communication with your team. I can't imagine any of us, unless, barring any sort of unforeseen circumstances, wouldn't be more than happy to support you and the team in that way. So let's keep those communications going, because the feedback has been that you're doing a great job, that staff are really appreciating it. Even if it's not coming out of the command center, you'll see even on these calls that we mentioned the last time, that the circumstances will evolve. The tool and the mechanism of communicating still remains pertinent and valuable. So please keep them going. Don't see that as a special thing that we did for this purpose. The special thing was the focus on this, and there'll still be some emphasis on this. Maybe it'll wane a little bit, hopefully, because it'll be consistent with us making progress in terms of keeping the community safe. But let's keep communicating about other important things for the organization, for the departments, for the units, and other areas.
Great. Thank you, you both, all three, for those comments. The next question is, as we begin to wrap down the stay-at-home or shelter-in-place process, Tony, question is, how long might we plan to continue to allow staff to work from home?
It's a great question. Thanks, Terry. I think some of it's going to be predicated on some of the answers from Delvecchio's oversight team, because as we start to ramp up services, that's going to likely lead to there being more patients physically in our buildings, and that may in fact require more staff depending on which area is working from home. So I think there are multiple things for us to look at. One is, what are we providing online right now through telehealth that will continue? And we don't know the answer to that yet until we've really studied that issue and there's work being done there. What areas have been working remotely that could reasonably continue to work remotely? And I think we're working our way through all of these. Some of them will be subject to bargaining. We waived a lot of restrictions so that we move people to the home office environment as quickly as possible as the shelter-in-place order came into play. That said, we have to now think about how does this look going forward. There are things that relate to workers' compensation, ergonomic requirements when someone's sitting at home all day. If they're sitting on their couch, that can lead to injuries. And while these may seem side issues, they become an issue when people are always working from home, and we have to consider those. So we've got to work through what is the patient need first and foremost, what lends itself to continue to work remotely, and how quickly do we need to ramp up in the office as to how quickly we would then bring people back into the space. I think we can't lose sight also that just because we're ramping up, there may still be restrictions or requirements rather on social distancing, and we've got to work our way through that and what we can effectively manage in the office space to keep the employees safe as we start to bring them back to the office space. And we're looking at different ways of dealing with that. And as we formulate that more through Delvecchio's oversight task force and other work that's being done, then we'll communicate out to everyone. But there's not a simple, straightforward answer because it's not a linear answer. It's going to vary by area. And as we come to those answers, we'll share and communicate that out.
Great. Thank you. During this process of trying to prepare to manage the COVID-19 surge or crisis, there have been a lot of new things that we've tried. There have been some best practices that we developed. We're doing some things differently. One of those areas that we've taken some significant steps in is around telemedicine. The question that's being asked, and Janet and Delvecchio, I'll send this to you guys, is, when will we resume outpatient clinics, in-person visits from telemedicine? And I guess the question I would have is, as you think about the question, how are we looking at continuing the utilization of telemedicine? Do we see it as a value added or something that we should be trying to roll back on? What are your perspectives on that?
I'll start. Well, Janet, you want to start? That's fine.
No, go ahead. That's fine.
So I put telemedicine in the bucket of things that we always wanted to do more of. We only had the ability to do a little bit of because of a couple of complications, I would say, in terms of capacity and bandwidth for the organization to be able to move in that space, equipment supplies, payer rules, and reimbursement policies and things like that. With the onslaught of shelter in place, we got better in that space. We got a lot of restrictions removed, and we were able to quickly ramp things up. The general feedback is it's worked really well. I've heard just anecdotally from many of our providers that they really appreciated being able to see patients in the comfort of their own home environment, so they're avoiding the traffic, they're avoiding the parking challenges that we have at many of our campuses, and they're able to have a really more engaged, in some cases, dialogue. I've heard of a few cases, the patient willingly inviting other members of the family unit into a conversation that helps them to support their care needs as well. So that has been very well received. My suspicion, and I will lean to the guidance and the expertise of our ambulatory providers and leadership on this, but to the extent that we can continue to support this capacity with all those restrictions that have been removed, staying removed or permanently being lifted, that we want to continue to do that. And we want to balance it with the ability to bring patients in when a in-person or face-to-face visit is warranted, indicated, and necessary. So that is the calibration that we'll seek to do. We absolutely intend and want to leverage telemedicine as much as we can for our community.
Yeah, thank you. I mean, the only thing I would add to that is that, you know, I think it's a very positive step forward, but I also think we need to balance kind of a hybrid model of how do you, you know, manage telemedicine when you can and it's appropriate, and then how do you balance those in-person visits with, you know, for example, pediatric patients or patients that need to have vital signs done or blood pressure or weights. And then on the inpatient side, we have been extremely fortunate that we kind of eased into it. So palliative care has secured a grant where they got a number of iPads, and so they've been able to provide palliative care consults and services to inpatients and link families into that. And then we already were in the arena of telepsych for behavioral health patients in the ED, which is, you know, again, allowed us to kind of ease into it. People are comfortable with the processes for the most part. You know, I think we've got some kinks to iron out in terms of what's the nursing role, what's the provider role, but I absolutely think we should embrace this and, you know, make it something that we keep as a result of perhaps, you know, a positive result from the pandemic for sure.
Great. Thank you. Dr. Bain, I want to follow up on a response you provided earlier because there are a lot of questions about testing in the ambulatory space. And one of the questions that comes up is, do we know when that may actually be taking place? Is there sort of a range or scope you might be able to provide around that?
We hope that this will happen very soon. I ambitiously had said, can we do this by the end of the week? And everyone said, that is way too ambitious. There's some moving parts around registration and space that we're still trying to sort out, as well as staffing. So maybe in the next week, fingers crossed. Know that this is like our #1 operational goal right now.
Great.
I would safely cap on and say next week is absolutely doable. So, you know, we've ironed out a lot of the kinks. We just don't want to kind of knee jerk it and throw it together for a Friday kind of thing and then, you know, have a bunch of issues pop up. But I'm comfortable that, you know, with Dr. Baden and Dr. Gupta is working on it. All the other departments have kind of come together this morning that we absolutely would be able to get this rolling next week. So stand by for more communication.
All right. Breaking news. I like it. Okay. The next question is around length of stay for COVID-19 patients. Is there a general rule of thumb around how long you should anticipate keeping a COVID-19 patient in the inpatient setting? Do we have a sense of that, or I'm sure it varies from patient to patient?
Like everything else with this disease, it's very unpredictable. So some patients have extremely short lengths of stay and are discharged safely to home to continue their isolation there. Others have quite prolonged stays and sort of fluctuations in their hospital course. So I wish we had a way to predict this, but like with everything else about this humbling disease, it's very unpredictable.
Okay. Janet, this is a question specifically for you. Are you ready?
I'm ready.
Okay. What is it about nurses that makes them so cool?
Oh, there's so many things. The list is endless, but you know, I think just that they are, for the most part, the word fearless comes to mind. That you know, those are the people that are typically ready to jump in and take on anything new. Flexibility, just ability to think on their feet. Their bladders are enormous. They can go a long time without having a bathroom break because they work so hard. I mean, there are just so many things that make nurses cool. And there's so many of us. So we truly do run the world, right?
All right.
I was going to say ice, but that sounds better. Yeah.
All right. Thank you, Janet. Due to the noted disparities in COVID, specifically within Black communities, are there any plans to deal with any existing racial or health inequities within communities of color here in Alameda County? Anyone? Did I confuse folks with the question?
Sorry, I was on mute, Terry. I think it seemed like it was a broader question. Rachel, you're on mute as well. We didn't hear you, Rachel. You're on mute.
Sorry,
what were you saying?
I didn't hear the question. Can you repeat it? Because about every third word came through.
As has been pointed out in different places around the country, there is disproportionate impact of COVID-19 on communities of color. And the question is, are we aware of anything that we might be doing locally to address those inequities and or disparities among those communities?
Well, I would just say off the bat, the most sort of immediate things that all of us were doing, both within our health system as well as the county, was ensuring that our systems were robust enough to track that experience at a local level. So to be able to cull demographic data from the tested population to see if we were detecting similar trends in terms of the at-risk population, including communities of color. And we have some data to suggest that that has been our experience here. It's a little different because of the kind of the demographic makeup of our county, but it is definitely indicators that the communities of color are having a higher incidence, I would say, of COVID-19, at least from what I've seen. I think the next thing will be then to figure out from that data what else would be indicated in terms of interactive, or I should say, I don't know if they'd be proactive because it's already here, but steps that you could take that would be more aggressive efforts to address the community. The biggest thing I would say for now is expanded testing. Goes back to the earlier comment that we really do need to get out in front of our lag now of low testing and figure out if this number continues or this percentage continues to bear out when you look at the entirety of the population. And then there may be subsegmentation of the population, whether by socioeconomic dynamic, housing or living status, whether they are in congregate living facilities like senior homes or skilled nursing facilities, things like that, where you have more targeted insight for what sort of things you could do to help to support those communities. But to the extent that it's based on clinical presentation in terms of comorbid conditions, then the reality, it seems to me, is that it's a reflection of the underlying disparities that we're already aware of and have been aware of and need to do more to address. But that's all I know at this point. No, Rachel or anyone else wants to add anything to that.
Okay. Great, thank you. Tough questions and hard answers sometimes. Through this crisis, we've had opportunity to partner with our county community, such as leveraging of hotels for patient quarantining and placement. These have been beneficial in many ways. Are there any discussions going on right now between Alameda Health System and our community partners to continue to utilize these creative solutions moving forward through our restoration and recovery phase?
Rachel, you want to speak to that? I can add, but I know you had the privilege of visiting one of the sites last week, I believe, and you may want to speak to that.
Yeah, so I had the privilege of spending my Thursday morning last week at Operation Safer Ground and Operations Comfort. So Operation Safer Ground is a hotel near the airport that's housing individuals in our community who are most vulnerable for COVID, but don't have signs or symptoms of COVID. So they're taking in folks who are age greater than 60 with medical comorbidities. And then right next door is Operation Comfort, another hotel where they're actually housing folks who may have signs of symptoms of COVID and offering them testing, or patients who've already been diagnosed with COVID and just need a safe place to isolate for the duration of their isolation. And it was an amazing experience just to see exactly what is happening there. I think it speaks, you know, as I said, to my department, right to the heart of our mission here at Alameda Health System. And so it's exciting to partner with them, and we have to figure out ways to continue to support them in this effort. I know they're in the process of opening at least one and possibly two more hotels. And I think the plan is for these to continue. I don't think there's any plan to stop this effort. We will continue to partner with them and support them. If anyone's interested in volunteering to help with these efforts, please let me know. We've had a number of folks in my department who've come forward and are going to help with some of the screening and testing. So I was excited about that. And if other people are interested in helping out our county and our community with these really important efforts, really let me know, and I can direct you to Harrison Alter and Kathleen Clannon, who are really leading these initiatives. But the work there is amazing, and I know that our patients appreciate it, our community appreciates it, and it was great to see what they were doing.
Great.
Yeah, I think great points, Rachel, and I would echo kind of a thanks to the county and other partners who've been able to stand those services up and to support our community and our organization in that manner, including folks in the organization who are helping with that. My understanding is that many of them, maybe all of them, are funded largely through state funding that's being provided to the counties in order to enable that resource. There's a question about how long the state or that source of funding will be available to support those efforts. But my understanding too is there's absolutely a desire to keep them going because there's absolutely a perceived need that continues. It has helped us a lot with throughput and appropriate placement of patients, whether they are well enough to not require an admission but need to be in a place where they can safely quarantine and isolate, as Rachel mentioned, or if they're coming out of the inpatient setting or any other setting within our system and others and still need a place where they can safely continue their recovery, but not remain in the inpatient or post-acute setting. So we're hoping that will happen. That's definitely one of the things that we're going to talk to the county about with our task force, with our board leaders, because we see value in it. And again, we see the need. The last thing I would say is I think the county public health officers, one of the other things they want to track with their expanded capacity is contact tracing. And as they are expanding their efforts to do contact tracing and identify then individuals who need that resource to isolate during their period of either being asymptomatic and potentially at risk or symptomatic, and they need to be safely or more reliably isolated. I think they see this as one of the vehicles that will continue to be used for purposes like that as well. So more to come, but we certainly hope that and are supportive of the effort to keep that in place.
Right. Thank you. As was mentioned earlier, there's a lot of fluidity to managing this crisis. Also, there'll be additional fluidity as we're looking at how we're going to restore other services. If a provider has questions about guidelines around isolation or who should be tested, particularly in an outpatient setting, where can they go to get additional information?
So if you go on the internet for our COVID page, there's a whole section that's dedicated to providers. And so we try to update that as soon as anything changes. So just this week, we updated the information around isolation to be in sync with the most recent guidance that came out in the last few days from the CDC, specifically about previously had been that folks need to stay in isolation if it's been 3 days without fever, improvement of symptoms, and then 7 days since symptom onset. And the CDC just recommended that 7 days be 10 days from symptom onset. So we just updated that guidance. And there is also specific guidance around our testing as well. And as soon as we change anything or expand anything, that section on the intranet will also be updated as well. If people have specific questions around the testing or questions, you can feel free to email me. I'm happy to people do, and so other people feel free to do it. I'm happy to answer any questions that come up around testing, isolation, or guidance. If a patient is hospitalized, the conversation around discontinuing transmission-based precautions should always be in conjunction with infection prevention because they help direct that. But that guidance has also recently changed and is updated on that section of the intranet as well.
Great, thank you. A lot of us are now wearing ear loop masks and other masks in general. How might these be, what are the best ways for these to be disposed of? Is there proper procedure folks should be using when they're done using an ear loop mask that we should be taking into consideration? Maybe Janet, any thoughts on that?
My thoughts are they would be disposed of. I think the interesting thing as you walk around your neighborhood and try to get out and get some fresh air is there are a lot of masks laying around on the ground, which is a little bit discouraging. But in our hospital setting, certainly to dispose of them as you would any other trash. They don't need to be put in a red bin. They don't need to be burned. We don't need to put them in a rubber glove. Just dispose of them and make sure that they're in a trash bin and not laying around or left on the desk or thrown on the ground outside. So. Dr. Baden, anything different you would add? But those are my thoughts on that.
Just for the regular ear loop mask, I completely agree.
Okay, great. So we have about 6 minutes left. I want to leave time for some closing remarks. I will ask this last question, has been asked before. Can the employees get the hat like the CEO? Their answer is yes. If you send an email to, well, until they run out, if you send an email to the PACE department email, we can facilitate getting you a hat as long as supplies last.
Maybe we just found a good hospital week gift, right?
Ooh, well, I'll check with my suppliers, see what we have. All right. With that being said, Davecchio, any closing remarks for this week's call?
Yeah, so once again, first off, I want to say thank you to my fellow panelists. Such a wealth of really detailed and excellent content from all the various angles. So your knowledge is just invaluable, and I really appreciate that. Also, once again, thank you to all of you for asking such wonderful and insightful questions and quite challenging questions too. Please know that while we sit here to provide information, we don't consider ourselves experts at everything, and so your insights and your questions really help to provide context for us and really help us to understand some of the things that we can share with you that we continue to struggle with as an organization as well. But we're struggling with that together, and we appreciate your indulgence, your support, your insights, and again, your continued commitment to our community and to our patients. Going back to the diversity question, I do want to mention that one of the things that we curtailed during the response and surge planning efforts was our health, equity, and diversity and inclusion task force work. We had just really gotten it off the ground, and a bunch of wonderful people who stepped up to volunteer to participate in some of that work that was establishing our baseline and some opportunities for improvement. And certainly COVID-19 has underscored some of the things we already knew, but maybe even raised a few other things. And that group's work is going to get gradually reinvigorated here. I'm meeting with a subset of the group next week, and the entire want to engage as many of the workforce as possible in helping us to identify areas of opportunity, both in terms of diversity and inclusion within the organization, but our efforts in health equity across our community. And your insights into disciplinary context there will be very, very invaluable. So wanted to say that again, and wanted to really appreciate the question because it's so core to our values here as an organization, and I know many of you really espouse that in the work you do every day. One more shout out to our nurses who are ice cold and really so incredibly valuable to all of us. Thank you all again for being here. Next week we'll talk even more about those plans for resuming services, as we'll have greater detail from the different groups at that point. If you have ideas or questions about things that, as we continue to evolve here, that we could introduce into the conversation, please feel free to forward those suggestions to Terry. Feel free to forward your shout out to Terry and to me. And once again, thank you for all of your time. Terry?
All right, everyone. Thank you again for your time. Appreciate your participation. Panelists are great. Wonderful questions. I like the fact we're breaking news on these things every week. So that's really, really good. And we'll look to see everybody again next week. Be safe, take care, and we'll see you next time.
Thank you.
Thank you.